again, so please give a rapturous welcome for the very wonderful Jacqui Dillon.
Bound to disappoint now, aren't I? Really. Thank you so much for that lovely welcome. So today I'm going to talk about the stuff I always talk about. I've seen quite a few familiar faces, so I hope that you dissociated through some of my last talks because I'm going to be saying some of the same stuff. So I often give this talk, the personal is political, and I think one of the things that was really crucial to my own recovery, I was somebody who was abused as part of an organised sort of abuse, an organised paedophile gang, which my family were involved in. And as I'm sure you can imagine, the consequences of that kind of abuse is absolutely devastating. To be kind of abused and exploited and betrayed by the very people who are meant to be protecting you was a shattering experience. And one of the things that happened for me is that when I ended up in psychiatric services in this very sort of broken state, hearing really distressing voices, feeling really paranoid, feeling really suicidal, and began talking in quite a fragmented way about the experiences that I'd had as a child, which I, even in this quite disturbed state, felt was kind of what was causing the problems I was having as a young adult. I was told that in fact these weren't real events, but what these were delusions, and that I was very seriously ill. And as I'm sure you can imagine, I felt kind of outraged by that response. And so I did what lots of patients do in those kinds of settings to get out of psychiatric services. I basically lied and told the professionals that were working with me at that time that actually they were right, that those weren't real events, because I wanted to get out of there. But that really was a devastating experience, and I guess a lot of my work comes out of feeling outraged by the treatment I received. I felt that the treatment kind of was more traumatising, and I often say it was like an insult to a kind of existing injury. And one of the things that the psychiatrist that assessed me said to me was, actually, Jacqui, we've had lots of other people in here reporting these kinds of experiences, but when we get their families in and we all sit and talk about it together, they realise that this is just part of their illness. And as I'm sure you might imagine, that made me feel slightly paranoid. And I actually wondered at the time if the hospital were part of the abuse, because the hospital that I was a patient in was actually the hospital local to where I'd grown up. So part of me wondered if this was part of a kind of massive conspiracy. And although part of me thought, well, maybe it's just a really bad service. And you know, in fact, when a lot of the Jimmy Savile stuff came out, you know, it's possible that maybe I wasn't just being paranoid, but who knows. Anyway, I was very fortunate to access some wonderful psychotherapy, and it was a really life-changing experience. And one of the things my psychotherapist did, I mean, he'd worked with lots of people who had had quite difficult experiences, but nobody who had had the kind of extreme stuff that happened to me. And also, the kind of extreme responses that I was kind of displaying and experiencing. And we began working together, and he was very upfront with me about the fact that I feel kind of out of my depth here, but I really respect you and I want to just kind of work with you and see if together we can find a way through this. And I actually really valued his honesty. And I think one of the things it did is it really equalised the relationship for me, because he wasn't putting himself there as this kind of expert about the stuff that happened to me, but being very honest and quite humble, I felt, about the need to just be there as a human being. One of the things he did is he handed me a copy of a book, which I often refer to, a book called Trauma and Recovery by Judith Herman, and for me, that book was life-changing. If you find anything that I've got of interest to say today, if you haven't checked out Herman's work, I'd really highly recommend it. For me, it was a kind of life-changing experience. And one of the things that Judith Herman talks about in her work is the ways in which people's personal experiences are, of course, happening within a much wider social and political context. Judith Herman is an American feminist, psychiatrist, And she likens women's experiences in the 1960s and 70s as, you know, where this notion of the person was political emerged from, that women's experiences of oppression and discrimination and the rest of it weren't just happening as because of a kind of personal failing, that actually, of course, it was happening within a much wider social and political context. And for me, that became a very important frame for thinking about my own and other people's mental health. So I think that political awareness as a young person, a distressed young person, was crucial to my own healing. And one of the things that I felt really passionately about is if I do get through this shit, I want to do something to bring about change. That's kind of part of what brings me here today. My talk is called The Psychological is Political, and that actually comes out of a Joanna Moncrief paper, which she wrote for Occupied Time. So it's online, it's a really nice paper, and actually it covers a lot of the stuff that Dave already covered this morning, sort of thinking about sort of the much wider social and political context, thinking about what the consequences of capitalism or neoliberalism been, and as Dave said, things like huge rise in prescription rates and things like, you know, lots more admissions into hospital, huge prison populations have exploded, and all the while the rich are getting richer and the poor are getting poorer. But what I want to talk about today is this concept of doublethink. So just quite a long quote from Judith Herman. So she says, the psychological distress symptoms of traumatised people simultaneously call attention to the existence of an unspeakable secret and deflect attention from it. This is most apparent in the way traumatised people alternate between feeling numb and reliving the event. So the dialectic of trauma gives rise to complicated, sometimes uncanny alterations of consciousness, which George Orwell, one of the committed truth tellers of the 18th century, called doublethink, in which mental health professionals searching for calm, precise language call dissociation. So for me, this idea is really powerful, both the ways, as Judith Herman says much more eloquently than I'm about to paraphrase, that, you know, the people's experiences of trauma both simultaneously draw our attention to the sort of, that something awful is happening, but simultaneously deflect attention away from it. So for me, this idea of doublethink is quite powerful. And one of the things that I've really noticed is that actually doublethink can be related to a whole load of things that happen in mental health. So not just the ways in which people kind of survive these awful experiences, but much more broadly. So, of course, doublethink, famously coined in George Orwell's wonderful novel 1984, where these residents of this dystopian universe are kind of meant to hold these very contradictory ideas as though they make sense. So the act of ordinary people simultaneously accepting two mutually contradictory beliefs as correct, and of course it's often within distinct social contexts. So it's the opposite of cognitive dissonance, because of course doublethink is notable due to the lack of cognitive dissonance. So examples from 1984, war is peace, freedom is slavery, ignorance is strength. So I think there are a number of ways in which doublethink operates within mental health services. So I'm going to sort of illustrate a few ways that I think it exists. And of course, this is one of the reasons why it does. As Judith Herman says, the knowledge of horrible events periodically intrudes into public awareness, but it is rarely retained for long. Denial, repression and dissociation operate on a social as well as an individual level. So I think this is part of why doublethink operates, because actually it is unbearable to be with the reality of how much suffering exists in this world and how powerless it makes us feel. So we all employ dissociation, I think, at different times, but hopefully there are moments of awareness. But I think actually society kind of encourages this kind of doublethink, and as I said, particularly in thinking about mental health settings, the ways in which doublethink are employed. So here are some examples. So this is a quote, I've anonymised this psychiatrist. So this is in response to somebody disclosing quite horrific childhood sexual abuse. And the response is, it would not surprise me if such abuse greatly worsens the psychopathology of a child already in the early stages of the illness. So essentially this happens, you know, you go on the Institute of Psychiatry or the Royal College of Psychiatry websites and you can see this way of framing people's experiences written in lots of different ways. But essentially what it's saying, and this is what I hear from people who use Hearing Voices network groups, is that I disclosed that I was abused as part of an organised network. I was put into care, I was sexually abused in care, I was bullied at school, and then I got into a relationship where I experienced domestic violence. And then I was told I had schizophrenia. And I'm told, oh, that's bad luck. You know, that on top of all these horrendous experiences, you've now gone on and developed this so-called biological illness. And of course, part of what upholds that way of thinking is this stress vulnerability model. Stress vulnerability model, in my experience, is taught in all mental health professions. So whether you're a nurse, social worker, doctor, psychologist, this idea underlies lots of theory. And of course, the theory, very simple, that people are born with genetic vulnerabilities and then shit happens, and that then tips them into having mental health issues. I mean, one of the problems about a lot of these ideas in mental health is that they are just ideas. You know, the stress vulnerability model is a hypothesis, but it's yet to be proven. And I guess one of my issues with it is that it privileges the biology and minimises the stuff that may have happened to the person. So I'm going to quote from one of my favourite thinkers, Mary Boyle. This is what Mary, again, sorry, it's a long quote, but they're just hard to summarise some of these. But Mary says, the vulnerability stress hypothesis has proved to be an extraordinarily useful and effective mechanism for managing the potential threat to biological models. Its usefulness lies in its seeming reasonableness. Who could deny that the biological and psychological and social factors interact? And its inclusiveness, it encompasses both the biological and the social, surely better than focusing on only one. While at the same time it firmly maintains the primacy of biology by making it look as if the stress of the model consists of ordinary stresses which most of us would cope with, but which overwhelm only vulnerable people. So we are thus excused from examining too closely either the events themselves or their meaning to the vulnerable person. And for a long time I had felt that the stress vulnerability model, there was something implicitly insulting to me about it. But Mary articulated it very, very well, because essentially what the stress vulnerability model is in essence saying is that somebody who was born more genetically superior than me might have coped better with the awful things that happened to me as a child. And as I'm sure you can imagine, frankly, that feels quite insulting. Some other examples of doublethink. This is from DSM-5. And of course, DSM-5, there was huge sort of fanfare when it was released in May 2013. And of course, we don't really use DSM here, we use the ICD-10, but of course, DSM often influences the sort of the new ICD. So Alan Francis, who actually chaired DSM Task Force 4, went as far as to say that it actually pathologises normal behaviour. So even Alan Francis, who I think is quite an old school psychiatrist, even he feels it's gone too far. So again, just keeping in mind this idea of doublethink. So these are some diagnoses from there. So temper tantrums in children. So children who have more than 3 temper tantrums a month for a year, yeah, are in danger. Particularly if they live in America, North America, those kids are in danger of being diagnosed with disruptive mood dysregulation disorder. And of course, what's so disturbing about this, of course, is that those children will most likely be medicated. This one, again, caused quite a lot of controversy, emotional reactions to the loss of a loved one which continues for more than 2 months, major depressive disorder, everyday forgetting characteristic of old age, minor neurocognitive disorder, and I think this is my personal favourite, Excessive eating 12 times in 3 months. Anyone here? Yeah. Well, folks, you are in danger of being diagnosed with binge eating disorder. And then a kind of darker example, for me a more disturbing example of doublethink. So this is from one of the very popular psychology undergraduate textbooks that's used in this country, although hopefully it will be superseded by the wonderful book that Dave and his colleagues put together, partly as a response to this kind of stuff, I think, this sort of idea of abnormal psychology. So this is a picture, this is the text which accompanies it. So paintings by sufferers of schizophrenia. Paintings by schizophrenia sufferers often have an odd, eerie quality. In many cases, the usual artistic conventions are disregarded, and the pictures include written comments, digits, and other idiosyncratic material. For example, Guardian Angels was painted by Elsa B., an institutionalised schizophrenic. In all her work, the legs of angels are painted as though they had fused at the top to make sure that nothing happens there. Now, I don't know about you, but if I was working with Elsa B., if I was her friend, if she was sort of doing lots of these paintings, I might wonder at least about some kind of sexual trauma. Never assume, of course, particularly when we know that 1 in 4 girls and 1 in 5 boys will be subject to sexual abuse. Then it feels legitimate to me that if somebody is painting this stuff over and over and over again, that they might be trying to communicate something. Does that seem like a kind of a sensible thought at least? But what we have here, I think, is a really nice example of doublethink, where all of this stuff that's being communicated is seen as odd and idiosyncratic because poor old Elsa B. is an institutionalised schizophrenic. And another example, again, this is quite disturbing. This is from a paper that a good friend and colleague, John Reed, did a piece of research, and one of the things he did is that he went and looked at patients' medical records, because one of the things John was interested in is the ways in which patients' disclosures were then recorded in their notes. So this is from that paper called Hallucinations, Delusions and Thought Disorder. So another's medical records read sexual abuse, abuse from an early age, raped several times by strangers and violent partners. This person believes was being tortured by people getting into body, for example, the devil and the beast, and had bleeding secondary to inserting a bathroom hose into self, stating wanting to wash self as people are trying to put aliens into my body. Another whose records reported childhood sexual and physical abuse and multiple rapes believes that has never been a child but is an old man who had his penis gouged out and had silicone injected into chest and hips. Another whose chart documents childhood sexual abuse also documents olfactory hallucinations, in brackets, smells, sperm. That last one always gets me. And the way in which the language is being used. So, you know, one of the problems with this is that this language is, I think, really drawing our attention away from the horrific things that people are trying to tell us about what has happened to them. And so this kind of terminology, like hallucinations, delusions, thought disorder, enables this kind of clinical assessment where we're able to kind of stand back, move away from the horrors that people are trying to disclose to us, and enables this kind of clinical assessment which creates a kind of illusion, or I would even go as far as to say a delusion of neutral objectivity. And Sami Tamimi, of course, Sami being a psychiatrist, part of the critical psychiatry network, and one of the things that Sami says is that this process, what it enables is that subjective opinion is able to masquerade as a fact. So in fact, all diagnosis is subjective opinion about somebody's experience masquerading as a fact. I think we need some aircon on. I'm melting. Are other people melting? We're melting. And I did a talk for Sammy last year, and I said to him, I often use that quote, Sammy, because I think it's really powerful, subjective opinion masquerading as a fact. And I said I would actually extend it, that what it is subjective opinion about somebody else's subjective experience. But yet, it masquerades as a fact. And of course, what is enabling that to happen is the power, of course. And so talking about people's experiences in this way invalidates, it mystifies, it renders unintelligible what I would actually see as, wholly normal reactions to the abnormal circumstances in which people have been traumatised. And it facilitates this kind of decontextualising, this distancing, so we don't have to really feel the horrors of the stuff that people have endured, and diminishes the suffering and denies these devastating experiences. And one of the things that really sickens me about this process is that it ultimately results in collusion and complicity, because it focuses on the deficits of individuals and this, this wholly deficit-focused way we have of thinking about people, rather than on the injustices of perpetrators. And when I talk about perpetrators, in my experience, of course, the perpetrators were quite obvious who the perpetrators were. But I'm talking about, I guess, perpetrators of injustice in the widest possible sense, really. So if we think about child abuse and neglect, school and workplace bullying, domestic and sexual violence, discrimination, poverty, unemployment, events which involve relatively powerful groups, governments, corporations, men, white people, adults, damaging less powerful groups. So in the case of emotional distress, context seems to include or even equate to the operation of power. And for me, we're really getting to the heart of it now. Why do we spend so long not really attending to the context? Because what it brings us to is to power and having to challenge power, which is a kind of scary thing to have to do. So we use all of these ways to deny context, and then we diagnose someone with a mental illness. So this from Lucy Johnston, diagnosing someone with schizophrenia is one of the most damaging things one human being can do to another. Redefining someone's reality for them is the most insidious and most devastating form of power that we can use. We haven't got time to get into it today. Maybe we'll in the plenary about what are the pros and cons of medication. Diagnosis. I know some people find them helpful, but I would like there to be alternatives. And because, of course, how long have I got left, folks?
Just over 5 minutes.
Okay, I'm going to talk really, really fast. Because, of course, actually, I'm not going to read all of this, but this is a paper that came out back at the end of 2012. And essentially what it's saying is that there are a number of studies now, and in fact these studies are accumulating at a rapid rate, showing that all mental health problems, including things that we label as psychosis, are often a consequence of a whole range of adversities. So looking at our early childhood experiences, attachment issues, things like witnessing interparental violence, the transmission of trauma from one generation to another. So, I was just in Ireland and talking to somebody who's doing a lot of work in Belfast with this idea of intergenerational transmission. And again, for me, it's probably a more interesting and helpful frame than something like genetics, which we can't do much about if it is true, although of course we're still waiting for a lot of the evidence. And then going on to some of the more obvious things that traumatise people that you would expect, so things like childhood sexual and emotional abuse, neglect. Neglect is an area that I think has long been neglected, and finally we're looking at the impact of neglect on children, bullying, childhood illness, war trauma, and of course all the stuff about poverty, racism and other forms of social inequality. So Suman Fernando's work is really important, looking at if you're a young black man in certain areas of London, you're up to 16 times more likely to be diagnosed with schizophrenia. You're more likely to be forcibly medicated, you're more likely to be sectioned, you're much less likely to be offered talking treatments. So I think, the British Psychological Society need to attend a lot more to the impact of race and racism. And Dave's already talked about this, so I'm not going to talk about this, but it's not just about being poor, it's about unequal societies. And, you know, not only are you more likely to go mad, you're more likely to die of cancer, get diabetes, have heart problems. It's pretty grim reading, actually. And then thinking specifically about childhood adversity and psychosis, lots of studies being carried out now looking at the impact of early abuse on children. So these are a couple of studies. Janssen et al., you're 9.3 times more likely to develop psychosis if you are abused as a child. Shevlin et al. Found that the people who had endured 3 kinds of abuse, so for example sexual abuse, physical abuse and bullying, 18 times higher risk of psychosis, whereas those experiencing 5 types, 193 times more likely to go on and develop psychosis. I mean, they're pretty extraordinary figures. And these are large population studies. These are not little 5s or 10s, these are thousands in the general population. Furthermore, individuals with psychosis 3 times more likely to have experienced childhood sexual abuse than those with other diagnoses, 15 times more likely to have been abused than non-patients. And I mean, I guess for me this begs a number of questions, but one of them is then what are we going to do to stop this shit happening to another generation of kids? And I think for me, one of the things we need to understand is why do people abuse children? Actually, because there seems to be quite a lot of it about, doesn't there? And that, for me, is something that we need to start addressing. And just to kind of bang home my point, again, this comes from John Reed's work. John Reed, I think, is a really good example of how to do clinical psychology outside of the therapy room. You know, most of John's work has been around research, or as he would call it, propaganda. But actually, this is really important in terms of the bigger picture, you know, actually providing so-called scientific evidence to back up what, of course, many of us with first-hand experience have always known. It's the bad shit that happens to you that drives you crazy. But, you know, only until we have evidence will people in positions of power actually listen. So John did a piece of research, and basically what he did is, because one of the things he believes is that people go mad for good reasons, that things happen to people. But one of the things that's upheld a biological model, of course, is that for some people, not all people, but for some people with a diagnosis of schizophrenia, for example, they will have changes in their brains. So an area of their brains will be asymmetrical, other areas will be more enlarged, no. And what John did is something very important. He actually got the fMRI scans of children that we know have been subject to awful abuse. We know it because it's contemporary, there's forensic evidence to back it up. And what he did is compare those children's brain scans with those who had been given a diagnosis of schizophrenia. And as I'm sure you can imagine, what he found is they have the same kinds of changes in their brains. So in fact, people may have differences in their brain structure, in their brain chemistry, but they are not born with those changes. Those changes are caused by the environment. So John is calling this the traumagenic neurodevelopmental model of psychosis. I said, blimey, that's a bit of a mouthful, John. And he said, well, it's got to sound proper, hasn't it? It's got to sound proper. So it sounds proper, doesn't it? And I think this is really, really important. I think it's important because it accounts for the reason why some, not all people have these kinds of differences in their brain structure. But what it doesn't do, so it makes sense of some of the biology, but what it does is it doesn't privilege biology. What it's saying is that, of course, our biology is intimately bound up in our social settings and in our psychological settings. And if anything, I think this privileges the social more than anything. So I think that's really, really important. I think the other thing that's really important, of course, is that these changes are not set in stone. There's a lot of really, exciting stuff. Finally, we're getting, I think, some really interesting stuff coming out. Looking, was that a wave? No. Looking at, the sort of neuroplasticity and the way in which the brain can change. That, and of course it's much more possible and happens much more quickly in children and adolescents, that sort of neuroplasticity, because their brains are still developing. But even in adults that have been chronically traumatised, there are some really interesting, I think really exciting studies now saying that actually with And interestingly, the thing that seems to make the difference is a long-term therapeutic relationships, which is often, of course, the thing that people may not have had first time round. So, for me, we think about the antidote to doublethink. What is the antidote to doublethink? And again, I'm going to finish with a Mary Wall quote, that in every presentation of distress, in theory, in research, in teaching, in case discussions, in media presentations, and in everyday conversations between service users and professionals, would have at its centre, unless there is strong evidence to the contrary, the idea that people's feelings and actions are consonant with their past and present experiences. So I think you, as clinical psychologists, as trainee clinical psychologists, but as the next generation of clinical psychologists, I mean, let's be honest, I was just saying to the guy sitting next to me that, you know, getting on a clinical psychology course, it's a bit like being Charlie Bucket, isn't it, with a golden ticket? You know, you are in a very, very privileged position. And, you know, one of the things that Mary Ball says is that your job is not just to placate psychiatry. Okay, your job is to speak out. Thank you for listening, everyone.